I am Dr. Rizin Kusop, the Vice President of Association of Private Practitioners Sabah, APS. Welcome again to our free live streaming webinar. During the session, as usual, if you have questions, please write them down early rather than later on the comment section in the YouTube platform, and they will be addressed by the speaker at the end of the session. Our speaker this evening is Dr. Alagammai Ramanathan. Dr. Alagammai graduated from Bangalore University in 1997. In 2001, she began her training in Obgyn in Queen Elizabeth Hospital and later in Sabah Women and Children Hospital. She obtained her postgraduate degree in UKM in 2009 and continued working in Sabah Women and Children Hospital. She underwent further training in ultrasonography in Chennai, basic IUI and seminology from UK, and advanced laparoscopic training in Kerala. She is currently working in Gleneagles Hospital, Kota Kinabalu, Sabah. The topic she'll be delivering today is antenatal care in GP setting, or rather primary care setting. And if we have enough time, we will also discuss some of the common medical legal cases that we could be potentially facing in antenatal care. Ladies and gentlemen, Dr. Alagammai Ramanathan.
Hello everyone. Hi, good evening. I'm Dr. Alagammai and I'm from Gleneagles, Kinabalu, Sabah. Right, without further ado, let's start what we want to talk about today. We're going to talk about antenatal care at GP setting. Right, is it important? Of course it's important. And it actually starts off with preconception. That is very important because that is where patients come to see you to seek opinion. They come to you because you are the first and you are the foremost primary care that we are looking at. All right. So why is it so important? Because currently we've got very young, educated society, and we've also people with late age of marriage. They want to finish studies, they want to do this, buy a house, settle down, get married. By the time they have their first baby, they're 36, 40, which is very common right now. Okay, it's also important because it actually helps us identify reducible and reversible risk. It also maximizes maternal health and hence the outcome. And hence it actually reduces our mortality. And we can also focus on what must be achieved before the conception. For instance, if your patient is very fat, for instance, say she's about 100 kilos, it's a bit difficult when she gets pregnant, right? So it's easier for her to bring down her weight before she actually gets pregnant. You want to look at the risk assessment, the medical as well as the psychosocial intervention. You need to be prepared to be a parent, especially nowadays, we have a lot of nuclear families. You don't have people to adjust. You can't get mates. There's a lot of things that you need to look into. As a friend, you could help. As a doctor, you can actually advise them. And of course, you need to establish a proper lifestyle. All right. And why is it very important? Because we want to prevent unwanted pregnancy and also other morbidities. We want to prevent birth defects, reduce the mortality of the mother as well as the fetus, and to prevent vertical transmission of HIV and STDs, and also to lower the risk of childhood cancer. So it's quite important. And what are the components you look into when they come? Number one, of course, you look into their nutritional conditions. Number two, you can actually screen them for anemia and diabetes, especially being in Sabah. If the patients come from areas like, Kota, Kota, we find that they have a lot of beta thalassemias and they marry among each other. So if both couples are thalassemic carriers, then there's a counseling that needs to take place before they actually get pregnant, because there's a 25% chance that they can have a baby with beta thalassemia major. They must actually understand that. Next is, of course, exercise. You want to do the genetic counseling if possible, and hepatitis B vaccination or any other vaccination, be your flu vaccine, your COVID vaccination. That's a good time for them to talk. And also your HPV vaccination. That's a good time to catch them because they're not really pregnant yet. So it's good to just introduce them to it, to talk to them about it. All right? Okay, let's go into the antenatal care as such. Antenatal care is basically to ensure that the women have a safe delivery. It's not to ensure that they don't have any disease, because we cannot be disease free. That is not possible, right? So we need to make sure that they have a safe pregnancy, so they have a safe outcome. It allows screening for medical and for fetal related conditions. So it helps us a lot in that way. Right. So booking visit, when should it be? It should be as early as possible. That's the best. But best between 8 to 12 weeks. So before 12 weeks is always the best. Okay. And the first thing you need to ask is, of course, the last menstrual period. But when you ask the last menstrual period, most of the times I find that the husband remembers it better in a way. The husband will be telling me the date, so I can actually trust the husband. The other way is, of course, they come to you with the app. So when they have the app, it's quite good. Then we know where it is. But it's also good to ensure that their menses are regular. If they have very irregular menses and on and off they take contraception, on and off they don't, then of course their LMP is actually not accurate. Then you have to look into their period of gestation, for which you need an ultrasound, because a dating scan is very important in the first weeks, especially when they come to us at a specialist level at 34 or 36 weeks. I cannot give them a dating scan. So it's very important that they have a dating scan and a proper date assigned to them and to be fixed with that date. Next is, of course, the history taking. Please highlight the important issues. For instances, you want to highlight whether they are diabetic, whether they are hypertensive, whether they had eclampsia previously. Those are things that we actually need to know, because that will decide where you want to refer the patients later for delivery. You can't just refer to anywhere just like that, especially if they had eclampsia. You know that they're probably going to have an earlier delivery. They're going to probably have another eclampsia this pregnancy. So you need to be very careful. So you need to know what you want to plan for the patient later. So previous pregnancy issues are very important, and please look into the medication and the supplements that they are currently on. We have a lot of patients, they're on methotrexate, they're on a lot of funny supplements that you don't even know what they are, what it contains and all that. So when they come for the preconception or at booking, I usually ask them to stop all the supplements that I do not know what it is, because you don't know the content. And medications, you need to see which is safe, which is unsafe, because a lot of them actually just walks to the pharmacy. Believe it or not, even with the normal cough, flu, fever, they don't come and see you. They don't come to the GP. They don't come to us. Straight, they walk to the pharmacy. They tell them, and the pharmacist give them the medication, including my blood pressure medications. The pharmacists are prescribing without knowing what is good, what is bad. Very simple. They walk in, check their blood pressure once. Oh, this is your blood pressure. Okay, ma'am, you just take this medication. That's it. So it's actually very dangerous, because no one is explaining to them anything. But patients as such will not understand, because for them they feel, oh, the GP is giving me the same medications, the pharmacist is giving me the same medications. So what? I don't need to monitor anything else. What they don't understand is what can happen in the future. So a booking visit is actually quite important, because they're in a good frame of mind at that time, and they're willing to listen. And believe me, when they're pregnant, they will listen to what you say, because they want to be very careful with the baby. So that's I would say, the best time to actually counsel patient on a lot of aspects for their future too. Because if they do have hypertension and diabetes, meaning they can have it even after delivery. So they're going to come back to you for the follow-up later. So you need to know what to tell them. So when you talk about examination investigation, of course, the weight is very important, because you would like them to have 1 to 1.5 kilos of weight every month. In total, the pregnancy, they should have about 12 to 16 kilos. More than that is a bit too much. The more the weight is, of course, their morbidity is a lot more. Vital signs monitoring is very important. Of course, you want to do a urine test to look for sugar and protein. If your sugar is present, you may want to do your MOGTT. A lot of them ask me, okay, sugar is actually positive very early in pregnancy. So do I go ahead and do the MOGTT? Actually, you can. But if the patient is having hyperemesis, how are you going to do your MOGTT? You give them the sugar, they're going to vomit everything out right in front of you. So practically, it is not possible. So what I do is, we do a fasting blood sugar, which is easy. So if the fasting blood sugar is abnormal, okay, you can just label them as GDM. That's it. If the fasting blood sugar is normal, I actually ask them to take their normal diet, and I repeat it back after 2 hours. I know it's not a proper MOGTT, it's not a 75 grams of glucose, but it gives me an idea at least, because I cannot force them to take the sugar at that particular time. So if that is normal, I wait for them to, their hyperem goes off. Once it goes off, then only we actually ask them to do the proper MOGTT. And of course, the funnel height or an ultrasound, if it's available, will be excellent. Ultrasound is actually much easier. Funnel height, yes, it's good for clinical. I'm not saying it's not. We all learned that. But going back to that basic, I think even when I do my fundal height, I don't know how accurate I am about it. So probably for me, I still go for ultrasound, which is easier. And look into their immunization, depending on how many weeks. Immunization, if it's due, please go ahead and give. Look into their rhesus factor, because we do have a lot of negative blood group people. So you need to give them rogam and things like that in early pregnancy. And you also want to do blood investigations. You want to look for HIV, VDRL, their blood group and things like that. And for chromosomal screening, if it is indicated. But usually when the patient comes to us in the first trimester, we explain to them what this chromosomal testing is. We don't force them to do it, we explain. So that can be done at your center too. You can actually explain to them what it is about, and it's actually entirely up to them whether they want to do it or they don't want to do it. Okay? So, number of follow-ups, that's the next thing that everybody asks me. Well, you should see the pregnant mother once a month at least if they have got no medical issues. What do you see? You look for weight gain, you look for the urine test, the MOGTT, a detailed scan if they want at about 20 to 23 weeks. Please remember, this detailed scan, we cannot force a patient to do it, but we can actually tell them, look, this is available and this is what we're going to look into. If you would like to do it, I would refer you to a particular center and you can actually get it sorted out there. Some of them do want to know it, but some mothers, when we talk to them, they don't, because they say, okay, doctor, if you do find out something at 22 weeks, are you actually going to do anything? So when they ask a question to you, straight away like that, then you know there are certain things that in Malaysia we can't do a lot of things, intervention, especially when the baby is tummy, right? What do? We do amniocentesis. Okay, I can tell you the baby is chromosomally normal or not. We can do CVS. What else? We can do blood transfusion for the baby if the baby is anemic. But I don't think we really do any surgeries intrauterine that much here in Malaysia as such, especially in Sabah, we don't have anyone doing it. So when somebody asks us, are you actually going to repair my baby's heart in the tummy? We'll say no. So sometimes they tell us, okay, that's going to stress me out by knowing, so I don't want to do it. So it's entirely up to them. But please document what you told the patient and what the patient has actually asked you. So that's important. Next, between 28 to 36 weeks, you see them every 2 weekly. Why? You want to see the fetal growth because you don't want to miss out a large baby, a small baby, a uterine growth restriction. You want to look into the AFI. And you also want to give ATT. Please remember, for a primary gravida, they get 2 doses of ATT, 1 month apart. And for a multip, if they deliver within 5 years, they get 1 dose of ATT. Or you can also go for a DTaP, because nowadays people are being more aware. They ask us for DTaP, so you can also give DTaP if it's available in your clinic. And once they reach 36, they'll be seen every week. And they need to be planned for delivery. So I suppose by that time, the patient already needs a referral. Until 28, it's actually quite easy to manage at a GP setup. Beyond 28, probably you need to consider when you want to refer to a place where they want to go. So why is ultrasound very important in the first trimester? Well, patient comes to you and say, I'm pregnant. And I'm like, okay, I know you're pregnant because, it looks positive, that's fine. But you can't just leave them off without scanning. Why? Because you do not want to miss certain things. For instance, when you look at this picture, you don't see a fetus in there. This is actually about 10 to 12 weeks. You don't see a fetus. You don't see a yolk sac. So you know that this is a delayed miscarriage. And we all know what's going to happen to this. So you need to explain to them before they actually announce the whole world that they're pregnant. And then, when they have a miscarriage, it's very painful. So it's easier for us to explain to them, look, this pregnancy, tak jadi. So probably this is going to miscarry by itself, or you may go to a center where they may have to do a DNC for you. So they would actually start thinking about it. Okay, that's one. This is another one that we need to know, because sometimes, when we scan, when we look into the uterus, this is the uterus. Can you see the fetus there? So once you see the baby in the uterus, most of us are very happy, We don't bother to sweep the ultrasound right or left and all that. So this is actually a patient where she did have an intrauterine pregnancy. She also had one outside in the tube. So she had an ectopic as well as an intrauterine. So this is called the heterotopic pregnancy. In Gleneagles, we have seen 2, and I have missed one. I mean, I'm not shy to say that I've missed. I have missed one. So because this patient came to us, she scanned, I saw the intrauterine. I did look left and right. I didn't find anything. So this baby, actually, the fetal heart stopped. So what happened was we went and did a DNC for her at about 10 or 12 weeks. And we thought it was all sorted out. HE came back. Memang it was pregnancy. And we were fine. 2 or 3 weeks down the line, she came back to the casualty. Very anemic. She was tachycardic. And when the MO scanned, they actually found free fluid. So the moment they found free fluid, when they called me, the first thing I thought about is, did I actually perforate the uterus, when I actually did my DNC? Because that's the first thing that comes to your mind. So we went rushing in. We saw a lot of fluid. Then I was like, okay, I have no choice, but I've got to take you up. So what we did was we did a scope, because that's the best to go in. When we did a diagnostic, we actually found a pregnancy that was in the tube and it was actually leaking from there. So we had to do a self-injectomy at that time, and I had to come out and explain, and HB actually proved it. So since then, I kind of phobia. I know, you keep looking right and left, even if you see a pregnancy in the uterus. This is another one which, sometimes, that patients can have a biconvex uterus. So when they have two horns, it can actually be in one particular horn, or it can be in between. It can be at the conval end. So when it's the conval end also, it can actually rupture. So this is also another scary thing. Another case that I could share with you all is, I think way back in 2001 when I was in Queen 1, there was this particular patient referred to us from casualty. I was at MO then. So they called us because they did a UPT which was positive, and they did a scan, there was free fluid. So a pregnancy positive and a free fluid is actually equivalent to ectopic for all of us, okay? Especially when you see the patient is pale and tachycardic, and there's some bleeding going on in there. And I was very lucky because they did a beta HCG, and the beta HCG was actually about 2,000 to 3,000, somewhere there, if I remember right. So, I was like so confident, this is pregnancy and it's an ectopic. So went in, opened up. In 2001, we didn't have a laparoscope here, so what we did, we actually opened up. And I saw all blood and blood clots. Cleaned everything. Her tubes were just perfect. Uterus was also perfect. I couldn't find any pregnancy anywhere. So started sweating. Obviously, you see so much of blood there and then you can't find the pregnancy. Called in my senior MO. She came in. She was also looking all around. Called in the specialist. Looked all around. We couldn't find anything. Then we decided, okay, we'll call the surgeon to come in. I still remember the surgeon came in, and finally Mr. Chua also came in. And zoop, they gave from up to down the scar. And finally, we found that she had a mass in the liver that was bleeding. So that was actually a beta HCG secreting tumor in the liver that was bleeding. But you see, all collection happens in the POD. So these are the things that we face. It can happen to any of us. So when we do things like this, I think the next patient, we kind of, we think, okay, can it be like that? Can it be like this? Not the best way to learn. It's easier when somebody does it and we learn from that. But sometimes when we face it, we'll remember for life. So is ultrasound important? Of course it is. It is for dating. You want to see whether it's twins, it's singleton, triplets. You want to see where the placenta is at the later part of your pregnancy. You want to see whether the fluid is okay or not, whether it's oligo or poly. You want to see whether the baby is big, small, what's happening. You want to, growth chart. And of course, you want to see the position of the baby. The most important is please document what you see and what you actually scanned. So, of course, patients will ask you, every time I come to the clinic, every month, you scan me. So, is this ultrasound safe? People say that taking an x-ray is not safe. Doing a CT scan is so unsafe. My baby will be abnormal. Please remember, ultrasound is only sound waves. It is not radiation. So, please assure your patients there is no known side effects to date, and it does not cause any birth defect, childhood development, or intellectual issues. And it's simple as long as the provider knows and is aware of the users. All right. When do you need to refer? Very simple, when you're not sure of the management. Okay. And of course, when the patient develops any medical conditions which need further inputs, when it's very near delivery. And we do have a lot of patients where I have a shared care between the GP and us. And it's actually easy in a way because they do all their blood tests there. It is a bit less expensive than doing it with us actually. I hope nobody from Gleneagles is listening. So when the GP does the blood test, they do everything and then they send to us, and then we do what we're supposed to, we send back. So we actually tell them, okay, we need this before the next next review or whatever. So in the sense, the patient has 2 doctors to care for, and they have 2 places to go to if they have an issue. And postnatally also, the patients come back to the GP. So when you look into the postnatal care, what you want to look at? You want to look at the wound care, whether it's an episiotomy wound or whether it's a Caesar scar. You want to see how's the wound. Next thing, we usually give the patient DVT prophylaxis. At Gleneagles, when they deliver under me or Shima, all patient gets DVT prophylaxis. They either get heparin or they get flexiparin or Clexane, either one of it. So this heparin, usually we give it to them and we tell them to go back to the GP clinic or to Clinic Kesihatan to take the injection. We have had one instance where because you see, the vial that we give is actually 25,000 in that whole vial. The dose that the patient is supposed to take is 5,000 BD. We do give a prescription, but sometimes patients tend to take a shortcut. Instead of seeing the doctor there, they just go. I don't know how they end up with a person who's there who just gives vaccination, and they just draw the whole thing from there and jab the patient. So the patient had 25,000 units of heparin. And the patient called me the next day, because we have a handphone number that they have a direct access to my clinic, and my nurse will actually call me immediately, whatever time it is. So the patient actually said, Doctor, habis sudah injection. Macam mana saya nak ambil 10 hari? We got a shock. How did she finish her ubat? You know, I mean, like, so I said, come back lah. So she came back to casualty that night. Then when we actually found out, she took 25,000 unit, and I was so worried because I didn't know where she's going to bleed from next, but thank God she didn't bleed. She was fine, and we had to discharge her back, explaining again. Probably there was some mistake from our side too when we explained, but we did give a prescription. But it's a bit difficult to explain to the patient, the vial has 25,000, so you only take 5. They're not going to understand. That's why we keep telling them, please go to a person who is professional. So if they have a GP, it's so much more easier, because we give a clinic kesihatan surat, the GP will look into it, and he or she can actually follow the dose easily. That's one. The second thing is, of course, contraception. That is also very important, because contraception, it's easier to talk to them when they're very friendly. And whom are they very friendly with? It's usually their GPs. So that's a good part to actually talk about. All right. Actually, for the antenatal care, nothing much I can talk. So I've decided to put some just case scenarios so we can discuss something on it. If there's any questions later, please ask. Yeah. Okay. You have a 36-year-old lady who comes in with an MOGT3 results of 5.1 fasting and 7.7. So does this click anything to you all? That's one question. Otherwise, she's under KKIA follow-up irregularly, meaning she goes, she doesn't go, she goes, she doesn't go. And she comes to you for second opinion at 28 weeks. Her blood pressure is about 160 by 100. And she was given medication by her friend, who is also a hypertensive. But she, being a smart patient, didn't take it, as she was worried of fetal anomaly, as per Google, according to her, which is very common, Nowadays, Dr. saya dah Google macam ni, dia kata macam ni. That's very normal, right? And fact is, she was given ACE inhibitor by her friend, captopril. And her booking HB was only 9.8. Clinic Kesihatan probably must have been calling her 100 times, but probably she didn't respond. We do have a lot of patients like that, right? So how do we advise her from that? Okay, so what are the issues that you're looking into? You're looking into a sugar which is slightly high. You're looking into irregular, that means a little bit of a irresponsible patient. You're looking about a blood pressure of 160/100, which is only now. You don't know what was it before that. And you have a friend who's a doctor at home, so-called, Bomo doctor at home. And she's still smart because she can Google. So you have a smart patient who's irregular. That's quite a difficult scenario to manage, yeah? Okay. So when you talk about GDM, you want to talk to them about diet control, advice on diet. You talk to them about carbohydrates, basically. And you want to tell them about the maternal and the fetal issues. You want to take a HbA1c if it's possible, so that you have a baseline. And you teach them to do a blood sugar profile. Okay. And one of the things that you actually offer them, metformin, or you can offer them insulin according to the blood sugar profile. You want to look out for babies that are big. You want to look out for polyhydramnios. You want to look out for fetal anomalies. And of course, breastfeeding is actually encouraged. So when you talk about GDM, of course, a value of 5.1 or more, it is considered, in fasting, is already considered diabetic. In fact, when I see this, I don't actually bother to do the second one. Why torture them by drinking, another 75 grams of glucose? Because this already tells you it's GDM already. Okay? But if you do the whole thing, your fasting is 5.1 or more, and 2 hours postprandial is 7.8 or more. If you talk about diabetes, fasting is actually more than 7 or more, and 2 hours is 11.1 or more. All right. Your target BSP, if it's fasting, should be 5.3, 1 hour 7.8, and 2 hours 6.7. But I do not give this value to my patients. Yeah, very clearly, I tell them I want your control to be between 4 to 6 kind of thing. And I don't really do the BSP like once in 2 weeks or once a month. What I do is I ask them to buy their own home-based glucose monitoring. I tell them to do a fasting on Monday. On Tuesday, probably do a 2 hours postprandial lunch on Tuesday. Wednesday is dinner, and pre-bed will be on Thursday. So meaning they poke themselves once a day. When they do that, I realized that they control their diet better. Whereas when I ask them to do it once a month or once in 2 weeks, 2 or 3 days before the BSB, they're very good. Their diet is excellent, so my BSB is beautiful. The day they finish their BSB, that night you'll see them sitting in KFC having their food. So in a way, sometimes I'll then tell them to do it, 2 days once if their control is very good. So I adjust it according to my patients, which you can do it anyhow you actually want. But if you want the right way, of course, what Clinic Kesihatan does is, once a month or once in 2 weeks, they do all the 4 dots on the same day. You can also do a 7 point if you need to. The next problem in the patient was actually anemia. So you're actually looking at the full blood count. You want to see whether it's thalassaemic or not, because it's quite important. Most of them have got iron deficiency anemia. So you can do serum ferritin, PBF, stool for OA and cyst, and urine FME. Why urine FME? You'll find that a lot of them have got blood in the urine where they don't realize before that. They may even have stones. And the amount of urine, you can't see it in the urine when it goes, but the microscopic you can actually see it. Yeah. So, and how many of us actually do urine tests when you don't need to? Very few of us. So I think that is also quite important. What can you do? You can actually start iron tablets, and you can repeat the hemoglobin after 2 to 4 weeks. At the hospital level, you can actually consider parenteral iron if unable to tolerate this iron or need fast iron to go up, or with patients with poor response to iron therapy. And of course, it is best to keep the iron above 11 grams. This I put up because I think it's quite important for you to know. Most of the medication we use, what do we use? Obimin, Zincofer, Ibaret, Sangobion, Maltover, right? So you need to know what is per dose and what is the elemental iron. So when you actually look into the elemental iron as such, of course, Zincofer has one of the highest. That's very true. Ibaret is supposed to have less gastritis. That's what they say. But many of my patients that are Ibaret, they're just not happy. They come back to you, they'll be telling you, I've got gastritis. But those who can tolerate is perfectly fine. But any one of this is fine, depending on what the iron level is. We also have very simple ferrous fumarate, which is 200 mg per tablet. It gives you about 30 to 60 mg of elemental iron. So this line is actually quite important for you to know, because depending on this, you want to choose which type of iron you want to give and what is the absorbability of it. It is very important, yeah. And it's also good to give it along with a vitamin C, because it increases the absorption. And please tell your patients not to take it with calcium. A lot of them, they're on Obical, they're on calcium tablet. It's easier to swallow 2 tablets at the same time, but the calcium will not allow iron absorption. So ensure they don't take it with milk, or they don't take it with the calcium. That is quite important for you to look into it. These are the small things that we tend to forget when we actually give them, so it's good to actually tell them. Parenteral iron, we have iron dextran, sucrose, and monofer. I'm quite familiar only with monofer because I've been using quite a lot of that. Yes, we do see about, say, 2 to 3 grams increase in 1 week, which is quite good for me. And I suppose, I'm not sure about GP setting, but I suppose all parenteral iron should be given at hospital or outpatient setting where CPR facility or a trained staff is available. As long as you think that you can resuscitate, then I think it's fine to give. But please remember, if you don't have a proper setting, then don't. So far with these medications, I've not really had anyone, collapsing in front of me, but we don't know. So that is the thing that, they tell you. So it's better to be careful. But we cannot give it in first trimester, in thalassaemic patients, in non-iron deficiency anemia, and those with known allergy to iron. So we can't do that. Okay, now next thing I'm going to touch about is hypertension, because these are the common things that we see, all right? So when you see a hypertensive patient, if you get to see them early, like the other patient was actually quite late really, say you see them at about 8 weeks, 10 weeks, it's wonderful if you can actually start them on aspirin. When you start on aspirin, it's 150 mg, it's once a day, or Cadiprin 100 mg once a day. So we give it right up to 36 weeks, in fact, 34 to 36 weeks. And you can also start on calcium at booking. These two will actually be very helpful when they come to us. Next thing, of course, you want to know which medications are safe and which is not. When you talk about safe medication, you're talking about methyl-dopa, which is very well known. It's been given over a very, very long time. And the dose is, 250 to 1,000 grams 3 times a day. The side effects you need to know is they'll come to you, they'll tell you, doctor, after you gave me the Uber, I'm just so sleepy, which is very normal because it's a centrally acting drug, but it's very, very safe on the baby. The next medication that you can consider would be labetalol. But labetalol, yes, it does cause some intrauterine growth restriction in the baby, so you need to remember that. So monitoring is important. Nifedipine when you want your blood pressure to come down fast. But remember, nifedipine, it gives you tachycardia and it also gives you headache. So when they have a headache, then you start thinking, is the headache because of nifedipine or is it because the patient is going into impending eclampsia? So you have a problem with that. So the safest bet would be methyl-dopa. If it doesn't work for that, maybe you want to try labetalol. If not, then you jump to nifedipine. Then of course you have all your IV medications, your IV hydralazine, your IV labetalol and things like that. When you look, of course, you got to look into your urine protein, the weight, and of course the baseline blood test. Baseline blood test, you're talking about uric acid, creatinine, LFT, the platelets, and things like that. You want to watch out for preeclampsia. Delivery, if the patient's on medication, is actually by 38 weeks, and breastfeeding is encouraged. I think this one is quite important because postpartum, the patient comes to you. See, when they deliver in the hospital, we monitor, say the patient's on methyl-dopa. What do? I stop the methyl-dopa because methyl-dopa, we don't give postpartum because it causes postpartum depression. We stop and we keep them in the ward for about what? 1 day, 2 days. So when we look at that, they don't, the blood pressure is okay. So we discharge them. We tell them, do your blood pressure every day. So say they go home and the blood pressure is, high. What do? They go back to their GP, which is normal. So when they go back, I think it's important for you to know what you can start on. So these are the safe medications. You can consider nifedipine, labetalol, captopril, enalapril, atenolol, or metoprolol. So usually what I go for is atenolol. It's easier, 50 or 100 mg a day, and it usually works. So try to avoid diuretics and angiotensin receptors. Yeah, so that's quite important. So let's go to scenario 2. So this is a 42-year-old lady, which is quite common nowadays. G4P3 comes in happily at 26 weeks for booking. Never had antenatal care. On examination, vitals were stable. Her BMI was 30, which is also fine. Previous pregnancy was uneventful, and she had a home delivery conducted by Bidan Kampung. She came to you, why? Because she had some bleeding after sexual intercourse the night before. So how do you think you want to proceed with this? So one of the things we are going to look into, of course, the first thing is you look into her age of 42. When the age of 42, of course, you're thinking, okay, is this baby normal? Is this baby not? So of course, an ultrasound will help and things like that. Her previous home delivery, so that scares you a little bit. So you need to counsel them. Hopefully, they've delivered the hospital setup this time. Next thing you're going to look into is her late booking. So what all have we missed out prior to this? We do not know. There's no dating scan. So we just have to assume that her dates are right and hopefully the ultrasound, corresponds to it. If it doesn't, you may want to change her dates. And we don't know about any medical illnesses. And she had no previous pap smear. So we have no idea whether there's a cancer sitting there, whether there's a polyp sitting there, and currently she's bleeding. So the first thing, of course, you look into is the bleeding. So you want to scan first. You want to make sure that it's not a low-lying placenta because you don't want to put a speculum or your finger in there. So you make sure it's not a low-lying placenta. If the placenta is up, please go ahead, do a speculum, see where the bleeding is from. Yeah, it can. We have instances where they have injury post-SI from the vagina. So there's active bleeding in the vagina. If it's just outside, you can actually take a suture. If you're worried, please send to us. Then, of course, you can see for polyps. You can see for any cancer which is sitting at the cervix. Because we do diagnose cancer during pregnancy and it's actually quite common. Right? So I think other than that, nothing much in this. Am I talking a lot? Are y'all okay? Are y'all tired? Do y'all want to listen more? Or y'all want me to stop here?
We still got some time. Plenty of time.
Okay, then can I have the second one? I need to bring it down. Okay, so I just thought I'll just talk about this medical legal case because it's kind of interesting. It's between GP versus a patient, which is not very common in ONG because usually the ONG is the one who gets sued, but in this case the GP was actually sued. All right, so this was a landmark case. It is actually all over Google. If you Google, you can read about it. It is something that we need to think about. Yeah, it is about Eve Toombs. This was very recent in 2021, November or December. And it was a case that I think all of us should know about it. Okay. So this is the girl. When you actually look at her, she's on all these drips and things like that. She's a rider, but you see she has all these attachments to her. So her whole life she's been like this. Okay, she has an esophageal tube, she has that, she has this, she has a lot of issues with her. This girl is a 20-year-old para show jumper. She was born in the year 2001. She was actually born with a neural tube defect and she had a surgery at 16 months of age. She also suffers from weakness as well as bladder issues and occasionally needs a wheelchair or a frame to go around. And at times, she needs to be connected to tubes for 24 hours. So you can imagine a life like that. And being a parachute jumper, she's very popular. And with all this, it kind of, puts her back. So what happened was in year 2021, she, the patient herself, who's now a 20-year-old girl, she decided to sue. What did she sue? She said it was a wrongful conception. Okay, when you think about it in a doctor's point of view or in a normal person's point of view, I think parents are the primary person in conception, not the doctor. The doctor is not the one who's getting the patient pregnant, right? So I suppose it's the husband and the wife. So I don't know what the doctor had to do with it. Any conception is prone for any kind of anomaly, miscarriage, or any other complication pregnancy. I'm sure all of us agree to this, right? Okay. So, but we need to know some facts about this, right? So Mrs. Toombs, she got married in November 2000, and in early 2001, they began to discuss about pregnancy. She had been on OCP for many years prior to that, and her last menstrual period is on the 13th of February 2001. She did not start her OCP on the 18th, which is day 5. Usually we started on day 5. She didn't start because she wanted to get pregnant. So she booked an appointment under GP on the 27th. Please note, 18th, she decided she's going to get pregnant. And then she booked an appointment under GP on the 27th. So for those of us, who starts calculating, I'm sure some of you will start calculating, you will realize that, her ovulation date is either 26th or 27th, somewhere around there. But her appointment is on the 27th for preconception counselling. And according to the patient, she had no SI before the counselling. But many of us, I'm sure we all have had experience where a patient comes to you pregnant and they actually tell you, doctor, I've never had sex. And you will find a baby in there. So sometimes you have to take that with a pinch of salt. Okay? So counselling at the GP visit, the main concern was whether she should go ahead with the conception as she had been on OCP. All right, which I think most of us would have said, okay, now we have already stopped the OCP. I think you should be okay to go on with with getting pregnant. And most of the times, most women don't get pregnant in one, stop OCP, the next cycle mengandung already. So it's quite rare. Usually they get pregnant about 2-3 months or something. And she was actually wondering if it is advisable to wait. She specifically asked on her diet and regarding folic acid, which she had read about. So she was told if her diet was good, it would be okay if she had not started it earlier to go ahead and start then. That means to go ahead and start at that time. When I actually sat and read through it, I said probably I would have given the same advice too. I would have told the patient, how's your diet? They tell me, oh, I take this vegetable, I take that, I take this. I also probably would have actually said, I think it should be okay to go ahead with the pregnancy because I expect you to have enough folic acid in the food that you take. When you read this case, then you'll realize, oh my God, I shouldn't have said that or I shouldn't do that, So believe it or not, most of us would have just written, what do you think I would have written on the case note? Most of us would have written her last menstrual period. She came for counselling, okay? And whether the menses was regular, irregular, the type of contraception she was on, maybe we would have wrote the BMI and other medical issues. Okay, and then we'll write there, treatment, start folic acid. Correct or not? That's what we'll write. Imagine 20 years later, we get a letter from the court. I don't think any of us would actually remember what we actually counsel because we don't write word by word of our counseling. So it's a bit scary. Many of us just write down, what is important. I don't think any of us write down when is the last SI or the exact conversation with the patient. Did she actually have SI before that? We wouldn't have written anything. And 20 years is very long. We really cannot remember anything. Okay, so the entire case was actually based on this visit only. This mother had only one visit with the GP and it was a 20-minute session. That's it. The whole case was actually around that. So she brought the claim in her own capacity when she was 20 years old, saying that it was a wrongful conception birth. If not for the negligence of the doctor on his advice, she would never have been conceived. And her mom knew about the folic acid needs to be taken at least 3 months in advance. she would have delayed her conception, and that would have resulted in a child without spinal deformities. This was her claim that she actually brought about. Okay, so of course, being lawyers, they know how to play around with words, right? Doctors were quite bad with it. Well, the doctor felt there was no legal basis on this claim. How can you sue for a wrongful conception? And he did advise on folic acid. And her LMP was on the 13th, hence she was fertile and would probably have been on the 26th. Her fertile period would probably be 26 or 27 of Feb, which was before his counselling. So for all we know, she may have been pregnant on the date of counselling, that is on the 27th, which sounds very convincing. I think any of us would have actually felt the same way. Well, there was the Civil Liability Act in 1976 regarding Congenital Liability Act. Yeah, this trial is very unusual as this was concerning with liability, so it's all factual, and hence they did not want any expert witness. Meaning, expert witness usually comes from a senior person who are doctors, of that sort in our field, but they had no expert witness and they did not allow. So it was accepted that if the judges were satisfied on the fact that if the doctor had not given adequate advice on folic acid, and the claims by the claimant will be successful. There's only 3 witnesses, that is the doctor, Mr. and Mrs. Toombs, and of course the judge. That's it. There's only 4 of them in there. The matters arise was, what was the advice given and what was the documentation? Not mentioning the need of folic acid, is it negligence? Was she already pregnant at the time of preconception counseling? And if proper advice was given, would she have delayed the conception? And did she have an intercourse in a folic acid deficient state? Yes, these matters arise were perfect. I think all 5 questions need to be answered. All boils down to documentation at the end of the day and memory. And Mrs. T, she actually went for a preconception counseling to increase the chances of having a healthy baby. That's what she said. And of course, that's true, right? She came to you because she wanted the preconception counseling. And she said she stopped taking her pills there, and she wanted to know whether the time frame is actually adequate or not. So she wanted to know whether it should be okay for her to get pregnant. And she said that she had refrained from sexual intercourse till the date of counseling, which is the 27th. She was told if diet was healthy, she need not worry of the folic acid. And she was advised to go home and have lots of sex, which was reported very blunt. But I think many of us would have said something like that too. It's not something that we wouldn't have said. So I can't blame the doctor there, So the doctor's evidence, very simple. He had no specific recollection through 20 years of this consultation, which is 20 years ago. And his notes actually only recorded very little, only 7 words: preconception counseling, advice, folic, if desired, discussed. Finish. That's it. It's like, cakar ayam there lah, okay? So usually what he said was, usually he would advise the patient on healthy lifestyle, ask them to stop smoking, alcohol, and he would also advise them to take 400 micrograms daily of folic acid in preparation for delivery and during the first trimester, which is what all of us would have actually said. We all know that, right? We know folic acid, 400 micrograms, 3 months before conception is the best. We would have probably said that, but do we document it? We don't. That's the thing. But the notes did not say that. According to him, this is a likelihood discussion. He said, this is what probably I would have said, because this is what I say to all my patients who come for pre-pregnancy counseling. And he says that this is what he does to all his patients. But because it was not recorded, the court did not take it as an evidence. So the court said, as long as not documented, it was inadequate. Records are poor, and now it is based on what you think and what is documented. So it is only an assumption. So the next thing is, if she was already pregnant then, well, her LMP is on the 13th, 40 weeks when you calculate it, it should be somewhere around the 20th of November. The child was delivered on the 19th of November. So that means putting her ovulation date as 26 or 27, right? Which actually corresponds. So the court accepted to the fact that she was not pregnant at the time of counseling, but was pregnant soon after. That means she went for counseling in the morning of the 27th, and that 27th night she got pregnant, and the claim of no sexual intercourse was taken into account too. the court said yes, that she would have delayed the conception if she had known, as she herself actively sought advice on folic acid before embarking on the pregnancy. So they said that, she herself came forward. She herself wanted, the counseling and all that. So she was aware of all this when she actually came. So since the doctor did not document, they did not, did not take into account. So they decided the doctor was liable, and the patient succeeded on this case, and no appeal was allowed. So it's actually quite sad, because I think there's a lot of case when you look into it, it boils down to documentation, to what we write. Even now, when I look back at my own case notes, I realize there's a lot of things that we don't write. Sometimes we decide, okay, should I actually record it? Is that going to help me? I don't know. These are things that we actually need to look up, and we need to decide. And whatever we tell the patient, try to document, or at least document it after the office hours. Once the patient balik already, then evening probably sit and write down, because 20 years down the line we're not going to remember. Please remember, in ONG they can sue us the first, I think, if I'm not mistaken, the first 7 years. Then subsequently the child can actually sue us once the child reaches the age of 18 to 21. So it actually goes on till the next 20 years for us. So antenatal care is not so simple. Just do it, but do it more thoroughly. Document, say it with a pinch of salt. Is that okay? Are you guys still there? So important, please write in the notes. Detail is important, and please write in proper handwriting so you can read what you wrote in 20 years. Our eyes is not the same after 20 years, yeah? So please write legibly. Thank you.
Thank you very much, Dr. Alagammai, for that very informative, interesting presentation. I got a bit of palpitation with the last case study that was presented. We haven't got a question yet at the moment.
Is anyone there actually?
Yeah, there are 45
Okay.
people logging into our YouTube at the moment, so I'm sure they are.
Be nice to have some questions for discussion. I'll answer if I know how to answer.
Yeah. Okay, let me start. This antenatal care that we're doing in GP, I don't know about other doctors, but for me, I basically follow what I have been doing when I was still with government lah. And recently, the government also producing quite a few new guidelines also. So that's clarify some of the update that we need to know. My question, I suppose, is this detailed scan. Is it compulsory for every pregnancy that you actually refer them for detailed scan,
No.
other than covering your own?
Yeah, basically you're doing it to cover your own. Yeah, basically you're doing that just to cover yourself. For me, what I do is I explain to the patient, because I feel when you do a detailed scan, you need to have certain qualification to do the detailed scan, and usually we refer them to the fetal-maternal medicine, a trained person to do the detailed scan as such. That would be the best. When we scan them, generally we kind of look into everything already, because we've been doing it for over 20 years now. So we kind of know what is right and what is wrong there already. But to have a proper documentation and, as you say, a legal chop, so they need to go to a fetal-maternal medicine as such. But before sending them there, I discuss with the patient first whether they want it or not. I make them understand the reason why we want to do it, and the reason what can we do. I also tell them in future, what can I do if you find out this, if you find out this. So some mothers are very anxious, they don't want to know about it. That's a patient's option, as long as they understand. And they must also understand that this fetal scan will not tell you about certain genetic conditions. It's very difficult to pick up, for instance, Down syndrome. You want to look at a flat nasal bridge, or you want to look at the ear which is lower. It is not. It's only soft markers. So sometimes they tend to put the patients in a more anxious position, so they get more worried. So we kind of tell them all that, then the patient will decide whether they want a detailed scan or they don't want a detailed scan. So we actually throw the ball back to the patient's court and let the patient decide what they want to do, because detailed scans are not very cheap, that's one. And number two is, can we do any intervention after that? For some, yes, but for some, no. So we discuss with the patient. When we discuss with them, we clear out a lot of other things.
So are you saying that at least we mention that?
Yes, definitely. In the
Of
first
course.
trimester, you have to mention, and at 20 to 23 weeks, you must mention. As long as you've mentioned, you've documented, you are safe.
Okay, thank you. Okay,
And there's a question there. And Dr. Ganesh is asking, in this medical legal case, was the penalty meted out to the doctor? Actually, the NHS paid out for it. So they said the NHS was responsible. This was actually UK, so they paid for it. But I don't know how much. And the next question I can see, can you explain about the chromosomal test? Yes, we do. When you talk about the chromosome test, we have currently what's more popular now is your NICE, NIPT and things like that, where you actually send them to the lab to take the blood and the results come back to you. So you must know how much of fetal fraction of the tissues that has been taken, and you also should know how to read it and explain to the patient. But before doing this, also you need to explain to them that what you are actually looking for and whether they want to know or not. Because we do have quite a few patients who tells me that even if the baby is abnormal, they're going to keep the baby. They don't want to do anything. So they don't want to know anything about it. So it is good to discuss and they decide whether they want to do a genetic screening or not. So I think that also answers the question, do you advise genetic screening during antenatal care? You're also looking at, your nuchal translucency, all that comes under the same thing. So the option is the patient's. Is the skin sensitivity test for parental iron reliable? Well, I'm not too sure about that. But when I give parental iron, I usually give them a test dose first. I still give and I wait for about 15-20 minutes. If nothing happens, then we continue. So I've not had any issues with that so far.
Okay, let's wait a few more minutes. See if we can get more question. Yeah, Ganesh said that a surprise expert opinion
Yeah.
on that case was not allowed in medical legal cases.
Yeah, but that was
But
the
I
main
think
thing.
that was in the past.
No, it's actually a recent case, 2021, very recent. But they said it was all factual. I mean, this is also from the lawyers and from what I read. So they said it's all factual, so they don't need an expert witness. But usually, when we have a ONG medical legal case in the court, yes, they do ask for expert witnesses, which is very common.
Okay. Okay, so there are no more questions at the moment. So one last question from me is, how would you advise us, the GP who's doing antenatal care, what sort of things, specific things that we should be referring to a specialist?
When you're not sure what to do.
Yeah.
Very simple. When you're not sure what to do.
Things like don't be a hero.
Yes, that's all.
Okay.
I mean, I'm not saying that I will know everything either. I probably will not know either, So it's always a combined care. I've called up KL. I've called up people, who are more senior than me to ask, what do I do next? Sometimes we are stuck in our management. So even if you don't refer, you think that doesn't need a referral, but you just need to discuss something, we are fine. You can call us anytime and just ask us. Of course, not a legal documentation there probably, but just as a friendly thing, how do you think I can proceed with this? So if a few of us gives you an idea, it'll give you an idea of what to do with the patient.
So there's no specific thing that we shouldn't actually handle. As long as
you're confident of what you're handling and you think that you're doing the right thing, I suppose that's fine.
Can go ahead with it. All right.
What's the maximum dose of metformin? 1 gram 3 times a day. How many tests would you advise in NIPT? Well, NIPT comes with all the 23 chromosomes, and they also have micro deletions. So they have packages, 8 micro deletions, 12, 20 micro deletions, and things like that. So that also depends on the patient. They want to choose which, because the payment goes according to that. But please remember, yeah, your NIPT is only a screening test. It's not a confirmation. It's only a screening. That's very important to explain to the patient.
Okay. Again, thank you, Dr. Alagammai. I certainly learned a lot in this webinar. Thank you all the GPs, doctors, paramedics out there who are listening, participating in this webinar. Now, please scan the QR code later on, rather, when we're showing it to you all. This is to get your CPD point. If you have trouble scanning them, please register your name at the link given earlier in this chat group so that your name will be recorded and will be awarded ICPD point. Thank you to our secretariat, Ms. Melissa and Mr. Adrian, for their assistance. Thank you to our sponsors, PetLab, and last but not least, we will give Dr. Alagammai again a few seconds or minute to give last parting words to us, all the GPs, about antenatal care.
Actually, there's no parting words, just document, document, document. That's it.
That's it.
That's
very
it. That's
important
it.
parting
Yes, that's
words.
all.
Document, document.
That's very important.
I must do my documentation properly as well. Okay. Guys, thank you. We will see you again in a few weeks' time with different topic and different speakers. Thank you and take care.
Thank you.